What if I told you that intentionally sending a patient home with a urinary catheter, which is, a complication most urologists actively try to avoid, is actually statistically linked to the highest long-term success rate for curing stress urinary incontinence? Welcome to the deep dive.
Yeah, it really sounds like a complete contradiction, doesn't it?
It totally does. But today we are taking a really fascinating look at the biomechanics and honestly the microengineering of urethral bulking. We've got a huge stack of manufacturer instructions for use, FDA data, and some really interesting clinical studies in front of us.
Right. And our mission today for you listening is to investigate a very specific clinical threshold. It's what physicians often refer to as the Goldilocks zone of injection volume.
Exactly. We're looking at why the absolute optimal injection volume per bolus usually hovers right around that 1.0 to 2.0 milliliter mark.
Because the ultimate goal here is to achieve adequate mucosal projection, basically stopping the leak during abdominal pressure spikes, but without crossing that dangerous line into urethral compression, which just shuts down normal voiding entirely.
Right, and to really grasp this, we have to set the stage a bit. For women, and occasionally men, suffering from stress urinary incontinence, or SUI, it's often driven by intrinsic sphincter deficiency.
Right, the inherent muscle tone and the mucosal apposition of the urethral sphincter have basically deteriorated.
Though historically, the gold standard for fixing that was a mid-urethral sling, right? Like
Yeah.
physically altering the pelvic floor anatomy surgically.
Exactly. But the paradigm has really shifted lately toward these minimally invasive bulking agents. So instead of mechanical slings, doctors are injecting specialized hydrogels or copolymers or even particulate matrices directly into the submucosal space.
Okay, let's unpack this. Because looking at the literature we have here, the whole procedure hinges entirely on like millimeters of tissue displacement.
Yeah, the fundamental objective is coaptation. You absolutely need the urethral mucosa to close perfectly, both at rest and during stress events, like coughing or heavy lifting.
Right, and the analogy I like to use to help picture this is it's a bit like weather stripping a warped wooden door frame. You are injecting this material to plump up the submucosa, basically restoring the integrity of the seal so no drafts get in.
That's a perfect way to look at it.
But if you apply too much weather stripping, the door just wedges shut. You might stop the draft completely, but you've also locked the person inside the house.
Yeah, exactly. And the weather stripping analogy works perfectly when you look at the different materials they use to rebuild that frame, so to speak.
Yeah.
The sources detailed two main categories of these bulking agents. First, you have your particulate agents.
Right, the ones with the solid microparticle.
Exactly, suspended in a carrier gel. Macroplastique is a really classic example of this. It relies on these textured silicone elastomer implants. And then there's Durasphere, which uses paralytic carbon-coated beads.
Carbon-coated beads, okay.
Yeah. But then on the other side, we have non-particulate hydrogels, like Bulkamid. And Bulkamid is so fascinating from a material science perspective because it is overwhelmingly just water.
It's like 97.5% water, right?
Yes, exactly. Supported by just 2.5% cross-linked polyacrylamide.
And regardless of whether a doctor is using a silicone particulate or that high-water hydrogel, the anatomical target is exactly the same. The injection is strictly submucosal.
Right. They're completely bypassing the lumen and staying far away from the deeper detrusor or sphincter muscles.
Right, they just want to place the bolus right beneath the superficial mucosa to create these distinct cushions or blebs that basically project inward to physically block that gap.
The spatial positioning is everything here. By placing the material submucosally, the doctor is leveraging the natural elasticity of the urothelium itself. The bleb basically creates a structural buttress, and that's what enhances the resting urethral closure pressure.
Okay, so if this entire clinical outcome relies on the size and the projection of those little submucosal cushions, then the volume of the injected agent is like the most critical variable in the entire procedure.
Oh, without a doubt. The physician is literally walking a tightrope. How do they achieve enough coaptation to stop the leaking without inducing iatrogenic urethral compression?
Which is what causes that urinary retention, right? The patient just can't pee at all.
Exactly. It's the defining clinical dilemma. The margin between a perfectly continent patient and a patient in acute urinary retention is separated by just fractions of a milliliter.
Okay, here is where I want to push back a bit, or, just play devil's advocate for you listening, based on the clinical studies in our stack. If the whole point is to stop stress incontinence, wouldn't a doctor systematically favor a larger volume injection?
You would think so, right?
Yeah, I mean, from a purely mechanical standpoint, aggressive bulking guarantees that the walls touch. If you want a watertight seal, shouldn't you just inject enough volume to ensure the gap is completely gone?
Well, what's really fascinating here is that the clinical data from a pivotal study by Williams and colleagues directly addresses that exact aggressive approach.
Mm.
The investigators wanted to explore the upper limits of injection volumes using macroplastique. So instead of these conservative microboluses, they administered a massive total volume of 5.0 cubic centimeters right at the mid-urethra.
Wow, 5 cc.
Yeah. Anatomically, they distributed it as 2.5 milliliters injected at the 3 o'clock position, and then another 2.5 milliliters at the 9 o'clock position.
That is just a massive fluid load for that tiny submucosal space. I mean, pumping 2.5 milliliters into a single lateral quadrant has to severely distort the urethral architecture.
Oh, it did. Looking at the Williams data, the immediate physiological fallout was profound. 48% of the women in that cohort experienced transient urinary retention.
Wait, almost half of them couldn't pee at all.
Exactly. The injection created such immense urethral compression that the detrusor muscle just couldn't generate enough pressure to overcome that artificial blockage. So nearly half the group required a post-operative catheter just to drain their bladders.
That's intense.
And the duration of that retention is really critical to look at, too. The mean length of time these patients needed a catheter was 4.7 days.
Almost 5 days.
Yeah, though the researchers did note some confounding variables. There were 3 outliers who had concurrent urinary tract infections or a history of Botox therapy, which, weakens the muscle anyway. But even when you strip those outliers out, the mean duration of retention only drops to 2.14 days.
Even at a mean of 2 days, I mean, you are fundamentally altering the patient's experience. What's supposed to be a minimally invasive outpatient procedure suddenly turns into a multi-day catheterization ordeal.
Right. It's a huge complication.
But, and here's where it gets really interesting and brings us back to that paradox I mentioned at the start of the deep dive. The Williams study tracked these patients longitudinally to look at their global improvement scores over time.
Right, the long-term results.
Yeah. And the cohort that suffered through that acute urinary retention, the ones who had to be catheterized because of that aggressive urethral compression, they actually registered statistically higher global improvement scores long term.
It's wild.
It is. A significantly larger percentage of that retention cohort achieved greater than 75% global improvement compared to the patients who were able to void normally on day 1.
It really is a profound clinical paradox.
Mm.
From a biomechanical perspective, it suggests that the aggressive volume not only ensures maximum and initial coaptation, but it might actually induce a beneficial inflammatory and fibrotic response.
Oh, so the tissue reacts to it.
Exactly. The sheer mechanical stretch on the submucosa, combined with that large particulate load of the macroplastique, it likely stimulates this robust encapsulation process.
I see.
The tissue essentially heals super tightly around the implant, creating this durable, long-lasting buttress that keeps its shape for years.
Okay, but that dynamic puts the physician in such a fascinating ethical and clinical bind. You have raw data suggesting that a 2.5 milliliter bolus maximizes the chance of a lifetime cure. But to get that, you're actively deciding to push the patient into temporary urinary retention.
Yeah, you are trading immediate post-operative distress for a higher probability of long-term dryness.
It's a really tough trade-off. But looking at the current landscape of the manufacturer guidelines we have here, it seems the medical community has overwhelmingly decided to optimize for patient quality of life up front and basically avoid deliberate retention at all costs.
Definitely. The distress of catheterization plus the infection risks, it just heavily outweighs those marginal gains in the long-term scores. And because of that, we see this unified pivot across all the device manufacturers toward really strict conservative volume limits.
Right. They are engineering techniques to secure adequate coaptation while keeping the total volume well below that 5.0 milliliter threshold we saw in the Williams study.
And if you trace that evolution through the device manuals, there's a really clear consensus around this 1.0 to 2.0 milliliter total volume standard.
So what does this all mean for you as you try to synthesize this data? Let's examine URYX, for instance. The technical specs for URYX dictate a highly conservative approach. The protocol strictly limits the initial injection site to a maximum of 1.0 milliliter,
Right.
and the total cumulative volume for the entire treatment session is capped at under 2.5 milliliters.
And the URYX instructions actually reveal this fundamental shift in the whole biomechanical philosophy. The manual explicitly states, and this is a direct quote, "complete coaptation of the urethral walls is not a goal."
Wait, really? Not a goal?
Yeah, that single sentence is a total departure from that aggressive macroplastique approach. The manufacturer is explicitly directing the surgeon to intentionally leave a slight anatomical gap.
Which seems completely counterintuitive, right? Until you analyze the actual material properties of URYX, it isn't just acting as a static space-occupying thing. The URYX compound is an ethylene vinyl copolymer.
Right, it behaves differently.
Yeah, the clinical objective isn't to crush the walls together to form a watertight seal. Instead, the material forms this cohesive, spongy mass inside the submucosa.
It provides dynamic compliance. So when the patient experiences a stress event, the urethral musculature actually contracts against this newly formed spongy buttress. It provides just enough resistance to prevent the leak without ever obstructing the lumen when it's at rest.
Relying on the material properties over sheer volume is just such a sophisticated evolution, and we see similar microvolume strategies deployed with Urelastic too.
Yes, the Urelastic guidelines recommend an asymmetric distribution, which is based on the pressure gradients of the local anatomy.
Oh, that's interesting.
Yeah, the protocol suggests up to 1.2 milliliters at the dependent positions, so specifically 5 and 7 o'clock, while limiting the upper injections at 2 and 10 o'clock to just 1.0 milliliter. By tapering the volume like that across specific quadrants, the doctor mitigates the risk of those projections overlapping and causing overcorrection.
Right, and the volume parameters get even more granular when we look at Bulkamid. As a non-particulate hydrogel, the total recommended volume for a complete Bulkamid session is a maximum of 2.0 milliliters.
For the whole thing.
Right. The standard technique involves depositing the hydrogel across 3 or 4 distinct mucosal sites, usually using a peace sign distribution, at the 2, 6, and 10 o'clock positions.
And when you do the math, if you divide a maximum of 2.0 milliliters across 4 sites, the injection volume per bolus drops to roughly 0.5 to 0.6 milliliters.
Wow, just tiny amounts.
Yeah.
So we've tracked this massive paradigm shift from a brute force application of 2.5 milliliters per site, which basically forced the urethra shut and caused widespread retention, all the way down to micro-injections of 0.5 milliliters.
Exactly. The modern Goldilocks zone prioritizes subtle, strategic structural support over just absolute occlusion. That 1.0 to 2.0 milliliter total volume limit is definitely the modern standard for achieving that adequate projection without risking the compression.
The data overwhelmingly supports that shift. But establishing an optimal volume limit in a clinical manual introduces a secondary and honestly arguably more complex mechanical challenge, doesn't it?
Oh, for sure.
A rigid volume cap of 1.5 or 2.0 milliliters assumes that tissue compliance is uniform across all patients. But in actual clinical practice, how does the physician accurately assess the precise tissue resistance and mucosal projection in real time? Like, how do they know that injecting exactly 1.5 milliliters won't inadvertently cause compression in a patient who has a particularly rigid urethra?
That is the big question.
Yeah.
Because a 1.0 milliliter bleb in one patient might give you perfect coaptation, while in another patient with, say, denser fibrotic tissue, that exact same 1.0 milliliter might severely compress the lumen.
Right. The physician can't just blindly rely on the little lines on the syringe. They have to continuously evaluate how the tissue is structurally responding.
And that's why the procedure relies completely on real-time endoscopic visualization. The injection needle is deployed through the working channel of a cystoscope. So, as the physician is steadily depressing the syringe plunger, they are visually monitoring that mucosal bleb expanding into the lumen on a high-definition screen.
It's all visual.
Entirely.
Yeah.
The standardized visual endpoint across most of these non-compressive protocols is to stop injecting the exact moment the advancing submucosal cushions reach the midline of the urethral axis.
The very second those bilateral blebs gently meet at the midline, you terminate the injection. The precision required for that is just staggering. And when you look at the technical manuals, they really emphasize an extreme level of procedural patience.
Oh, absolutely.
Returning to the URYX protocol for a second, the instructions mandate an exceptionally slow injection velocity, specifically a rate of approximately 1.0 milliliter per minute. The physician has to sustain a perfectly static needle position while advancing the plunger at a glacial pace.
And that super slow velocity is not just arbitrary. It is strictly dictated by the chemical properties of the URYX carrier fluid. The ethylene vinyl copolymer is dissolved in dimethyl sulfoxide, or DMSO.
Which acts as the solvent, right?
Right. It keeps a polymer in a fluid state so it can actually be injected. But once it's deposited into the submucosa, the DMSO has to diffuse outward into the surrounding aqueous tissue environment. And as that DMSO dissipates, the copolymer basically precipitates out of the solution and solidifies into that spongy mass we talked about.
So if the doctor rushes the injection, pushing the fluid faster than that 1.0 milliliter per minute, the DMSO can't diffuse efficiently. The fluid just pools, creating a localized pressure spike that prevents the copolymer from precipitating uniformly.
Exactly, which completely compromises the structural integrity of the bleb.
And beyond just the material properties, rapid injection velocities dramatically increase the risk of localized ischemia.
Yes, the manufacturer guidelines contain severe, explicit warnings about tissue blanching.
Blanching, like turning white.
Exactly. As the physician watches the cushion expand on the monitor, the urothelium has to keep its vascular pink appearance. A sudden shift to stark white indicates an immediate hemodynamic crisis.
Which is pretty straightforward hemodynamics. If the tissue turns white, the mechanical pressure of the fluid expanding inside the submucosa has just overpowered the capillary perfusion pressure of the blood vessels.
Right, the bolus is literally crushing the microscopic blood vessels and causing acute ischemia.
And prolonged ischemia in the urethral mucosa inevitably leads to tissue necrosis, right? Like sloughing or ulceration right at the injection site.
Which is exactly why the moment blanching is observed, the protocol is absolute. The physician must halt the injection immediately, regardless of whether they've reached the target volume or achieved that midline approximation. Preserving blood flow always supersedes the goal of coaptation.
It really is a remarkable high-wire act of clinical observation. The physician is simultaneously tracking the mechanical expansion of the bleb toward the midline, they're monitoring the tissue for ischemic color changes, and they're ensuring the cumulative volume stays below that 2.0 milliliter threshold.
It's a lot to manage all at once.
It is. And the complexity doesn't even end when the plunger bottoms out. Looking at these manuals, the withdrawal of the needle is just as highly regulated as the injection itself.
Yeah, the withdrawal phase requires strict adherence to hold times, and that all comes down to the fluid dynamics of the newly created bleb.
Right.
The injection generates a high-pressure, localized pocket within the lamina propria. If the physician immediately retracts the needle, the pressure gradient is just going to force that meticulously measured volume to track straight back out through the puncture hole.
You essentially create a geyser, just voiding the entire therapeutic volume right back into the urethral lumen.
Exactly. So to prevent extrusion, the protocols dictate mandatory needle hold times to allow for viscoelastic creep and pressure equalization. With macroplasty, for example, the doctor has to hold the needle in position for 30 seconds post-injection.
And for URYX, because the DMSO diffusion and precipitation require more time, the needle has to remain completely static for a full 60 seconds, just sitting there.
Right. This gives the puncture tract time to actually seal around the precipitating polymer, which locks that precise volume right inside the submucosal space where it belongs.
Which is just incredible. But, if we connect this meticulous protocol to the bigger picture here, this raises a really important question regarding the future trajectory of urethral bulking.
Yeah, it does.
Currently, avoiding iatrogenic retention while hitting that perfect adequate projection, it relies heavily on subjective visual interpretation.
It really does. The physician is relying on two-dimensional cystoscopic feedback, subjectively judging when the blebs meet at the midline, and, visually checking the mucosa for subtle color changes.
It basically boils down to an incredibly educated, highly skilled eyeball test.
It does. But consider the potential for eliminating that subjectivity entirely. Like, what if, in the near future, the injection needles themselves were engineered with integrated micropressure sensors right at the tip?
Oh, wow.
Right. Rather than relying on a visual estimation of the midline, the needle itself could dynamically measure the localized tissue compliance and the exact closing pressure of the urethra in real time.
So the system could just automatically stop the bolus the exact microsecond the submucosal tension hits the proper physiological threshold.
Exactly. It would eliminate human visual error completely.
Yeah.
It would definitively prevent ischemic compression and urinary retention while practically guaranteeing mathematical coaptation for every single patient.
Integrating dynamic pressure telemetry directly into the injection cannula would completely revolutionize this procedure. It would take a subjective visual art form and turn it into an exact, reproducible biomechanical science.
It really would.
I want you to really ponder that as you process today's deep dive. We are rapidly approaching an era where resolving intrinsic sphincter deficiency won't just depend on a doctor's visual assessment of a 1.5 milliliter bleb, but on algorithmic, real-time tissue mapping. Until then, mastering that optimal injection volume remains an absolutely fascinating testament to clinical precision.